Great. Good morning, everyone. We are so excited for you to join us. This is not necessarily a new format for us. As many of you know, we've been sharing our membership meetings virtually for some time to kind of improve access and allow those that don't attend our normal in-person conferences at a regular interval. So we are pleased to still be able to do this even in the absence of our in-person conference. So I'm delighted that we can all, connect in this way. We have a lot of exciting things on a little bit of a new format for you for those that have been with us for previous conferences. I do want to let everybody know before we get into the actual content of the meeting that we are recording this meeting so that it can be made available to those not in presence with us today. I just want to say a couple of welcoming remarks about my real love for working with this group. All of you included, the professionals in this group and the students really give me a lot of inspiration and enthusiasm on a regular basis. This work is so very important. As we all know, this population of patients so vulnerable, and this work is so important. So I just wanted to express my gratitude to all of you and applaud your continued efforts, even in these tough times during this pandemic. So please continue to move forward and use all of us as resources as we do that. As I briefly mentioned earlier, we have a little bit of a new platform for our meetings. We are going to work towards providing some education for our professionals and students that attend to improve our clinical expertise. And so we have a world-renowned faculty with us this morning to share some of their experiences with what has transpired in their variety of settings through the pandemic. So without further ado, as mentioned, we have a lot of content, exciting content for you this morning. I'm going to introduce you right away to Courtney Witzak, our education chair. She's going to take it away and introduce our wonderful speakers as mentioned, and then kind of explain how the CEU process will work this morning. Thanks, Courtney.
Thank you, Lori. If everyone can look at the screen, there is a survey for online speakers. There also is a QR code if you have a smart device to fill out the survey at the end of this presentation. The survey link will be emailed out as well. If you could please put your chat name in the chat box, we'll make sure that your attendance is recorded, and within 1 week you'll be getting the participation for your PDR verification. I'd like to introduce the speakers. I'm so pleased to do this. Gumti Kanapke is an acute care physical therapist from Michigan Medicine. She has more than 14 years of experience and received her bachelor's degree from Government Medical College in India. She has a postgraduate diploma from Rehab from Bombay, India. She's a clinical specialist in general med, pulmonary, and oncology. This entails programs orientation to PTs, updating orientation material, and making competencies. Most of the time she works in the surgical and medicine ICUs and is part of the oncology rehab team at Michigan Medicine. She has many poster presentations in the combined section meetings on topics including to rehab and oncology population at early mobility in the ICU. Our speaker after Gumti will be Julia Osborne. Julia is graduated from 1994 in the University of Cape Town, South Africa. In 2002, she moved to Denver, Colorado after practicing from general oncology rehab, and in 2014, she's Associated Clinical Education Institute, the Physiological Oncology Rehab Institute. Julia focuses her expertise in life's expert work on integrating evidence-based clinical research into developing oncology rehab protocols and management of optimal patient outcomes. Additionally, Julia creates and directs clinical course writing and development for PORI and presents oncology clinical education for rehab therapists both nationally and internationally. In 2019, Julia attained her board certification in oncology physical therapy specialist through the American Physical Therapy Association. Also in 2019, Julia became a Fulbright specialist for world learning in the field of oncology rehab. Julia takes tremendous pride in growth and development of the oncology rehab team and as a PORI instructor team. And she is dedicated to the clinical expertise and clinical education of both teams and delivers patients with cancer diagnosis. Our last speaker will be Dr. Sarah Arena. Dr. Arena is a home care physical therapist Henry Ford Home Healthcare. Additionally, she is an associate professor in the physical therapy program at Oakland University. She has received her entry-level physical therapy degree from Grand Valley State University, a master's in science, and a doctor of science in physical therapy with a certificate in teaching and learning from Oakland University. While her home care role covers a broad demographic region, she primarily serves older adults in northeastern Macomb County. This has been actively providing home care throughout the evolution of the COVID-19 pandemic. She is actively engages in research, focuses on promotion and health awareness in community dwelling and homebound individuals with the emphasis on blood pressure management. Additionally, she is co-principal and co-founder of a home-based or HAP Up PT LLC, home-based older persons upstream prevention physical therapy. Dr. Arena's professional awards include Michigan Physical Therapy Association's Outstanding Clinical Instructor Award, the APTA Award for Clinical Excellence in Acute Care, and the Michigan Home Care Association Certified Outstanding Service Award. And without ado, I'll pass that over to Gumti. We are so happy to have you all.
Good morning, everyone. Hopefully you guys can hear me. Okay. I am. Thank you for being here. As Gumti said, my name is Gumti. I work in Michigan Medicine. It is my pleasure to present the first case and in the morning. So we had, I'm presenting a case study of one of our individual that came to us in admission, in multiple admissions that he came during this period, but this time he was symptomatic of the COVID-19. So he had been positive before, but this time he had symptomatic. The whole concern was why he was symptomatic this time and not the other times that he had come, even though he was positive for the most time. As you can see, he's a 60-year-old male with the history of germ cell tumor and mantle cell lymphoma. He had multiple chemotherapies during his course of his oncology history. He did have a bone marrow transplant, which is autologous in 2016. He did have a recurrence of his disease, which he went multiple rounds of chemo again. And then he was on immunotherapy for the last couple of, I think still at least before he got the symptoms, which would be around July, August. He was tested COVID positive in June 2020 without having any symptoms. Functionally, he had been doing really good till he came to us at least in August. And he didn't have any supplement needs, even though he had to be on the COVID. I know this slide and the next slide is super busy, but I just wanted to give you guys an idea about what his medical history was while he has been going through all of this time. So it's a huge one, but I think the one that comes to mind more on this one is the mantle cell lymphoma, the chemotherapy-induced thrombocytopenia, because he did get admitted to us one time for bleeding and lower hemoglobin and blood counts, and on top of what the oncology disease would do. He did have bone marrow transplant. He did have COVID-19, which was diagnosed in June because he came for, I think, an infusion and he was not feeling that good. Nothing were symptoms, but they found he was positive because we were doing COVID testing at that point. And he had pneumonia with it. And on top of that, he did have nausea and some anxiety that didn't help him while his course of therapy. Oncology history, I know nobody can read this. It is super, super, super busy, but I do wanted to highlight that if you could just look into it, or from 2002 to 2020, this gentleman has been going through multiple rounds of therapy, chemotherapy, immunotherapy, his transplant, relapse of his disease, and a lot has been going on through him. So when he came to us, the whole thing is like when he came to us, the anxiety level for this person was so high that when he was talking to me, he just said that he just doesn't feel like he's gonna make it because he has all of this and, going through COVID. Now COVID-19 is added to the list of his history because he had humongous history of treatments. Now he's gonna add 4 more things to him. He did have, like, if you look at it, like 6 rounds of Nordic it's okay, Courtney. It takes 6 rounds of Nordic regimen, then transplant, and then multiple chemos. So he came to us, I think in August, around August. He went to a different hospital because he was having fever and he was having some cough, and he went to a different hospital. From there, because he has his bone marrow transplant oncology care with us, they transferred him to Michigan Medicine and on August 24th. But before that, he was also admitted to us in sometime in July for bleeding, and sometime in June because he was positive, but not symptoms wise. Then also in June, he did have history of pneumonia, but he never needed oxygen. He never had cough. He never had secretions or anything at that point. So we did send him home. He went home. He said he quarantined himself. He was staying in a trailer outside his own house at that point, not staying with his family because he thought he might, even though he didn't have the symptoms, he did quarantine himself. And he told me his quarantine was more than 2 months because he was just so worried about his family at that point. When he, in July, in August, when he went to the other hospital, he had fever and cough. So they sent him to us in Michigan Medicine, and the diagnosis was he had multifocal pneumonia. Even at that point, his oxygen in the ER was totally fine on the day of the admission. But he was there for like half an hour, and then he started feeling shortness of breath. So we had to give him on supplement oxygen. So that was the point in August where he was more symptomatic than anything, that he was short of breath, he was fatigued. He said in the last 2 months he had a weight loss because he couldn't eat, because he was nauseous due to his chemo. He said he couldn't carry on his ADLs every day doing things, and he definitely was tachycardic. His white blood cells, his hemoglobin, everything was trending down, and maybe that was the reason of chemo, but having that didn't help him to go through this. This was just his medical management. This time he got like multiple of antiviral, antibiotics, and definitely remdesivir. But I also wanted to point out here that the first time when he had the COVID, he did get remdesivir and the convalescent plasma to keep, and then he was positive for his antibodies in June. His regular other PRN were acetaminophen because he was in pain. You would know he was on melatonin because he was getting anxious and he couldn't sleep through the nights, and we kind of needed him to rest a little bit. So this anxiety and nausea were also taken care of while he was inpatient with us. This is the medical management of him in August. So to briefly say, he was with us like on 24th. We got a consult on 25th. For some reason, his platelets were down, so we couldn't see him on, the therapist chose not to see him on 26th, but when we saw him on 27th, he was pretty good mobility-wise, function-wise, in the room, just because we could only assess functional mobility in the room because we couldn't get him out of the room. But the only difference at that point for him having COVID and most symptoms that were pertinent to us was he was using 3 liters of oxygen at that point. And it said like when he would be using 3 liters with mobility around the room, but at night he was using about 6 or sometimes 9 liters because he would get anxious and he wouldn't be able to sleep and will say, I'm breathing, and he would cough. But he was able to clear his secretions at that point. So we didn't focus on doing airway clearance because he had pneumonia with his symptoms. So we didn't do any airway clearance, but we mostly focus on trying to do as much activities as we can in the room and give exertion so it would help him to cough and stay as strong as we could. I think he stayed with us for like 7-8 days, and we got like 3 sessions because he didn't need any more of that. In acute care, you kind of see the patients as they need us, not like continuously. So he was doing really good, modified independent, everything. We did leg exercises, we could do stairs, everything we could. So that would be the treatment that we usually do. I just wanted to point out here a tiny bit about our standard of care for oncology population in our hospital. We do have like we have a walking program and a strengthening program that we perform with our patients, so they can walk in the hall, or if they can't get out of the room because of something, we do have portable treadmills that we can bring into our patient's room, and that's how their ambulation for endurance happens. We do have pedal, like a bike we have a small outpost, we have a bike, we take our patients there, we have staircases, we have TheraBands and weights and, regular stuff that we give it to the patient. But even though in this COVID time, maybe he would have definitely benefited a lot more with a little bit more aggressive endurance exercise program, but we just couldn't take him out of the room. But we were able to bring a staircase into his room to practice stairs. So when he goes home, he'll be able to manage them. So the whole question was, the whole thing was, even though the whole reason for me to present this paper was why in June he didn't have the symptoms, and why in August he did have his symptoms coming up. So the belief was that when we said that even though he had an active disease all these months coming from June to August to September, it was concluded that he was on immunotherapy, like his last dose was 2 weeks before he got the symptoms, that the immunotherapy, the chemotherapy did wipe out all of his antibodies that he developed from COVID. And then he was back to having symptoms for COVID. So now the whole thing is, my question is, are we going to be adding COVID-19 as a complication of chemotherapy going down the road? I know we probably will have to do a lot more research and investigations on it if the patients are going through COVID in coming time. Would COVID-19 be one of the complications that we might have to chemotherapy? I know it was short. Does anybody have questions?
There was a question in the chat box from Janet Seidel.
Okay, hold on.
Could you share some more information on portable treadmills?
Portable treadmills, like it's a treadmill and a walker is hooked onto it, and you can take it, you have to plug it to the wall socket, and then you can take it to the room. It's portable. You can just walk with it. It does record your speed. It does record your time. It does record your calories or distance, calories to it. And we got it for our patients mostly that can't leave the room. Some of our lung transplant, pre-lung transplant, post-lung transplants that usually walk on vent or ECMO. We walk our patients on ECMO. And the whole reason to get them was that if the patients are on ECMO or on vent, it's a lot of it very easy to transport. A lot of 5 people needed to walk a patient on ECMO. So we thought if we can bring one device that negates 4 people, then it is easier. It is a little bulky. It's not that I'm gonna say, but it's a very useful piece of device.
Great. If anyone else has any questions, please include that in the chat, and we'll have for Gumti, and we'll address those at the end of the presentation. Thank you, Gumti.
Thanks, Courtney.
Dr. Arena?
Hi, everyone, and thank you to the SIG for inviting me today to share a little bit of my experience in the home care environment. Many of you know me as a faculty member at Oakland University, but today I'm actually going to be presenting from my clinical role as a home health care provider. Go to the next slide. Thank you. So I'm going to just talk real briefly today about some of the barriers and challenges in the home care environment, kind of an area that you don't hear a lot about on the news, but we were essential workers and quite active throughout the entire pandemic. And then talk about some of the changes that happened during the pandemic and those that are persisting and those that have gone back to normal. And then just overview 2 of the patient examples that I saw during that time period. So obviously lots of clinical barriers and challenges for all of us, but this uncertainty in an uncertain time, day one, okay, start washing your hands more. Day two, okay, now you better wear a mask. Day three, wear a mask, wear gloves. Day four, wear a mask, goggles, gloves. Day five, wear a mask, goggles, gloves. And now the patient wears a mask, and you know the story. We all kind of went through that. And we did that in a time when PPE was available to us. I never had a time I didn't have PPE, but it was limited. So I might actually have to drive 20 miles that morning to go get my PPE for the day, just to make sure I was helping to make sure there was enough for everyone. So that definitely added more time onto my days. And something that people may or may not think about when you don and doff your PPE in a controlled environment. I was donning and doffing outside a patient's home. And so there were days there was a 50-mile-an-hour wind, and I had a gown on, and you can imagine what those little paperweight gowns were doing in that wind. And so kind of that fear for yourself of kind of blowing this virus everywhere as you're trying to get your PPE on and get your PPE off in kind of this outdoor type of a setting. As many of you know, many outpatient clinics were closing. So in a normal time when we would discharge someone and pass them along next to our outpatient colleagues, that was absolutely not available anymore. So we became outpatient therapists as well. Thankfully, the government regulations allowed COVID-19 to be a homebound criteria. So it was a feasible option during this time period, and still is. Something that was kind of a barrier for many of us, one advantage of home care, especially as a working mom, is if your patient cancels, you go run to the grocery store and kind of fit that into your day. And you certainly didn't want to walk in any location with your scrubs on, and because you got quite a dirty look. And even now, I'm not doing that at all anymore. Also, just as many acute care therapists I'm sure dealt with, or others working out in the field, I'd text my husband, I'm on my way home, and he'd have the garage door open, and there I went into the garage and closed the garage and stripped down and yelled into the house as I walked upstairs and got my clothes in the washer and got my shower. It became kind of part of my workday. As well as we designated one of our cars as our COVID car. That it was our larger of the cars and a little older, but there was a dirty box and a clean box, because I don't have a place to throw away contaminated items when I'm outside a patient's home. So at least during that time period, we had our designated COVID car. And something you may or may not think about for those of us in home care is, we don't really have bathrooms in our car. I don't use a patient's bathroom generally, but some of our clinicians do. But you certainly now didn't want to be using a bathroom in someone's home who had COVID. And then McDonald's was closed. So there were a lot of challenges with bladder retention during this time period, now that we didn't have those available. Some of the things specific to the oncology population, many people were avoiding the ER because that's where you get COVID. And so people that were in need of medical services and their physician was recommending going to the ER weren't going to the ER. And so their cases were becoming more and more complex. And on more than one occasion, I was calling EMS in patients' homes, really pretty much forcing them to get to the ER. Because their saturations were in the low 80s and variety of things. And people were not choosing long-term care facilities even though it was medically appropriate for their recovery, because they wouldn't be able to be with their families. So we were not only no longer having the outpatient end of things available to us at the same volume, we were getting people right from acute care who would normally have gone to a long-term care facility. So the complexity and our ability to fully treat these individuals was really quite challenging at times. And obviously, if someone's getting radiation and chemotherapy, which is part of their recovery and intervention with an oncology diagnosis, there was fear in going for these. And in many cases, it was paused. So there was not treatment going on if there were risks. We did a lot of transition into telemedicine and telerehabilitation. I'll kind of mention that in the case in a moment. That became more available to us. And one other kind of barrier was that many of the cancer treatments overlap with COVID signs and symptoms. And so certainly that was a challenge as well. Everyone was getting a mask. We were using tons of gloves to follow universal precaution. We were clustering care of COVID populations, so we may see all of them on one day and all the non-COVID on another, or half day type of a scenario. Practice changes also include, like I mentioned, telerehabilitation, and now we're monitoring our temperatures. And then some changes to our patient care really weren't changes at all, but rather ramping up of our existing policies, like a pre-call and screening. And you know, something to be aware of is that we had patients that were technically, when we call and screen them for COVID, were not telling us the truth because they were worried we wouldn't provide them care. We were really doing it more for knowing what volume of PPE to wear. But we were having to be very cautious with that because sometimes they were worried their care would be compromised if they told us they were having COVID symptoms. During that time period, we didn't bring our laptops into the home, so that added more documentation time onto our day. But I was very thankful my agency did do a daily morning huddle with all the changes that were happening. Every morning, 8 to 8:15, we got the latest updates and were well informed of what was going on and what the newest things were. So just to give you a kind of a scenario of the types of patients I was seeing, I'm going to share a story of two individuals. The first was someone who had pancreatic cancer. And when I was seeing her, there was very significant fatigue and shortness of breath. And originally, the physicians really felt this was just a side effect of chemotherapy and radiation therapy, and they were doing some telehealth visits with her. But ultimately, when she finally went to an ER, it turned out she had COVID-19, which was believed to be contracted during one of her chemotherapy appointments. And she had other cardiovascular types of medical sequelae as well. Her evaluation included severe shortness of breath. And when I say severe, she would stand and do 5 marches and it would be 4+ dyspnea. So she was having significant dyspnea with exertion, dropping in saturations, was very tachycardic. And because of this and some of her balance issues, had a significant fall risk. So her family was staying with her. They had also contracted COVID in their care for her. So they were all in her home, kind of isolating together, other than me as the home care provider entering into their home. And she was having difficulty with many of her functional activities. So some of our visits, and many times it really wasn't safe to do just telerehabilitation. Rather, I would do 1 in-person visit a week to address things, and then we would do 1 time a week a telehealth visit. So kind of doing this back and forth to limit the contact, but making sure I was progressing her and offering her all that we have, all of our skill set. Many things related to energy conservation and fall recovery. I don't think many of these interventions were really unique. It was just kind of the precaution aspect that was the challenging part of it. And, you know, getting the DME, a variety of exercises, and we really used dyspnea to guide her exercise dosage. And our next patient is someone who had lung cancer. She had had a lung resection and now had a new lower lobe lesion. She was having severe chemotherapy-induced nausea and vomiting. So again, this is during the course of those early days in the pandemic became one of the potential risks of a COVID diagnosis. So certainly something to think about. Lots of comorbidities with her as well. So the severe nausea and vomiting was limiting her ability to be active. She was showing evidence of dehydration, tachycardia, low blood pressure. She was lethargic, ashen color. And generally she could do things, but this dehydration and her nausea and vomiting were causing significant decline with her. And so our interventions really revolved, again, I did the 1 time a week in person and the 1 time a week telerehabilitation. She had a family that were able to help in facilitating holding a screen for our telerehab visits. I did collaborate with physicians to get her into an infusion clinic. Although this is obviously a scary place to go, that was definitely an area that she needed. So they were taking lots of precautions there, but that certainly kind of helped to peak her up and help with those dehydration side effects. And so certainly many of the education things similar with our first case, giving her her rolling walker. She did eventually progress to an assistive device, progressing her seated to standing exercises, increasing her aerobic endurance with walking, and then doing some of the typical in-home care functional activities, bed, shower chair, and so on. And so just in conclusion, we really had no service interruption in our field, despite many of these barriers and challenges. And home care PTs really were out there serving individuals that were recovering both from COVID-19 and those with very complex diagnoses, including those that were persons living with cancer throughout the height of the pandemic and presently. I think that's the end of my part.
Does anyone have a question for Dr. Arena?
And hopefully I didn't talk too fast, but I wanted to respect my 10-minute limit.
If you do, please put them into the chat box. Our next speaker will be Dr. Julia Osborne. Thank you.
Right, well, good morning to everybody. And again, thank you very much for inviting me to be part of this morning. So as per the introduction, I am presenting based on outpatient. And we have a slightly different scenario from what's been presented by Gamadi and Sarah, in that we can actually really control our patient environment. Here in Colorado, where our numbers have been relatively high, but not as high as some other parts in the country, we actually, thankfully, have not yet encountered a patient coming into our clinic with active COVID symptoms. And a lot of that is because of the controls that we've been able to put in place. Number one. Number two, a lot of that is because patients obviously are concerned about interactions and feel, I think, a lot of self-responsibility in terms of spread, etc. But it was a pretty intense experience going through the earlier months of this year, and I would like to share some of that with you. I think what I would like to highlight in my presentation this morning is what we need to understand about COVID down the road. What the research is showing is that some of the symptoms, while very acute, subside into a subacute to almost a subclinical presentation for a period of time, and then can begin to re-manifest down the road in terms of the sequelae of COVID. And so that's what I would really like to focus my presentation on this morning. So without further ado, I'm going to step into this. And this is what I've done with my my colleagues as well, is just really making sure that we're understanding that we have preparedness for these patients coming to us, that we understand what the disease process has added to their cancer diagnosis and their cancer treatment journey. And so my presentation is a little bit more about what is actually happening inside the patient versus a case study directly. So one of the primary manifestations, as we all know, is significant lung tissue inflammation and a cytokine cascade. And this significant inflammatory response obviously causes some damage to our patient's lungs. And then when you superimpose that damage on top of radiation fibrosis, if the patients receive radiation into the chest area or the trunk area, and also certain chemotherapy drugs that can cause pneumonitis, we then have some compounding issues that we need to be considerate of with these patients down the road. The predominant manifestation of the lung damage results in mechanical restriction of lung tissue. So it's our responsibility to understand, what does a mechanical restriction actually mean? And essentially, obviously, what that means is a dyspnea type of presentation, which what the research is showing is can actually dissipate somewhat acutely and subacutely as the patient begins to recover. And you can actually have a subclinical manifestation of this. However, what they're seeing is that there is a resurgence of this a few months down the road, and ultimately it can result in a progressive exertional dyspnea that they are concerned may have very long-term effects for all patients, but especially our oncology patients. Obviously, there's a higher risk for pneumonia, not only acute and subacute, but also long-term because of the lung damage. And then for us, from a clinical perspective, these are some of the manifestations that we should be looking at for our patient population. Dyspnea, fatigue, peripheral muscle loss, which would essentially include the respiratory muscles, cardiac impact because of the pulmonary impact, nutritional changes, and psychological impairments. That would probably mostly align with cognitive impairment, resulting from some of the hypoxia that the patients may have experienced acutely or subacutely. What I wanted to show you was an illustration of the patient's lung tissue. It has this classic marble type look, and you can actually see on the inferior portion of the right lung, you can see some of the fluid collection, and you can actually see some resolution. You can see as it peaks through the disease process and then some resolution towards day 15. But the main thing is just to understand that our patients will probably have this type of presentation long term. That's going to certainly impact them down the road. Next slide, please. Thank you. So as I said, the research shows that in terms of the lung fibrosis, you often have an early manifestation that is very obvious. However, the actual symptoms, the sequelae, can be subclinical over long term, as I've said. And this can result in latent side effects, which in an outpatient facility, this is probably where we're going to be picking up more of these issues is down the road, particularly if you have a patient who has had COVID and then subsequently gets an oncology diagnosis. So we have to be cognizant of that with our population. Next slide, please. Thank you. So in terms of the oncology patients, their primary trajectory overall is surgery if they have a solid tissue tumor. If they have a liquid tumor, then surgery is not necessarily involved in their treatment, but predominantly most patients are going to receive chemotherapy, either neoadjuvant or adjuvant, as well as radiation. And it's the chemo and the radiation that we have to be cognizant of. So in terms of the radiation, primarily those who receive radiation in the trunk area, chest wall area, this would be your breast cancer patients, as well as your lung cancer patients, melanoma, sarcoma, anybody who ends up receiving radiation in this area. We have to be considerate of the fact that we end up with a radiation-induced fibrosis that is also a chronic sequelae of radiation. You superimpose that with somebody that has COVID, and you have some compounding pulmonary issues that can actually manifest. So if I can show you the next slide, you'll see the presentation is very interesting. So on the left-hand side of your slide, that presentation, that large impression, is actually of a patient with radiation-induced fibrosis in their lung tissue. Now, obviously, radiation is delivered today to be very cognizant of that, but it is very interesting to look at that manifestation of radiation-induced fibrosis and see how similar the presentation is with a COVID fibrosis. Very, very similar, resulting in a mechanical loss of function and ongoing fibrosis for the patient. So these are things we have to be cognizant of. In terms of chemotherapy, the two groups of chemotherapy drugs that tend to cause a pneumonitis in patients are drugs from the systemic group, as well as drugs from the immunotherapy group. So anytime you have a patient on systemic chemotherapy or immunotherapy, then certainly one wants to be concerned and cognizant of the respiratory issues that can occur with these patients. And again, it can be difficult to differentiate the dyspnea from a chemotherapy side effect versus a COVID/chemotherapy side effect. However, the management ends up being much the same. So in terms of management, we want to look at clinical assessment. And what the research is showing is that you can do these various different types of tests, looking at the patient's 6-minute walk test, gait speed, 5 times sit to stand, strength testing. You also want to do cognitive testing and a quality of life. And so pulling out of the research, these are the standard tests and clinical assessments that have been suggested for an outpatient scenario. Additionally, lung function testing, if you have the ability to do that, spirometry, certainly looking at the patient's posture over time. Down the road, they're going to become kyphotic if they end up with this type of fibrotic manifestation. Diaphragmatic breathing is going to be compromised. Spinal rib mobility is going to be compromised. There are going to be certainly myofascial restrictions in the trunk area. We're going to end up with intercostal weakness and decreased coordination. There's going to be a lot of accessory muscle use in this patient population. The research also recommends the duration of rehabilitation in outpatient setting should perhaps be somewhat extended. And so the recommendation is to start the patient low and slow and then move them along appropriately. The recommendation also is the earlier that you start the patient, the better, the more chance you have of working against some of the mechanical restriction that is progressive because of the fibrosis. And so again, a low and slow program, keeping the patient in care for an extended period of time. Right, and so predominantly what our experience is preparedness for our patients who have had a COVID diagnosis coming into our clinics latently down the road, understanding the interception of COVID along with an oncology diagnosis and oncology treatment, particularly radiation, chemotherapy. We're also having to be prepared in terms of the treatment area. So we have a designated treatment room for patients that have had a COVID diagnosis. We also have designated equipment for patients that have had a COVID diagnosis. We also have a process in terms of which therapists would be specifically involved in managing these patients. And so we are looking at more future preparedness for these patients coming into our clinic post-diagnosis. In terms of our response during the pandemic, when it was at its peak and we were experiencing our shutdowns, obviously one of the first things that had to happen was an extensive amount of leadership. Had a lot of people becoming very, very panicked and concerned. We are essential workers. However, in a clinic of over 50 people, we decided to minimize exposure and reduce ourselves down to a skeleton staff. We opened the clinic only 3 days a week. We only had 4 therapists working at a time. We kept them spaced between each other in the clinic. And we also staggered our patient appointment times so that there was no patient crossover. We also obviously had to allow for adequate cleaning time. And we also had to make sure that we had enough PPE to service our staff and also provide patients with masks and things that they may need coming in to see us during that time. We also did morning huddles on those days. And then as we reintegrated back into our clinic with everybody returning to work, we did morning huddles and every single day delivered an email to the entire staff so they knew exactly what was going on at all times. There were lots of changes happening, as has been indicated, and so we had to keep up with that to the best of our ability. Today, we have an ongoing screening program, and we still do a weekly huddle where we just make sure that we're up to date with everything and feed that information back into our staff. What we're struggling with today is staff members having 2nd or 3rd type exposures, as well as patients, and working out what we need to do around that. And predominantly the decision is that anybody who has any kind of exposure has to stay out of the clinic for at least 7 days. And so this is certainly a barrier to our care. But with that, I think I will end there, and certainly happy to hand over to any questions. Oh, sorry, there are a couple more slides. I apologize. So the take-home message conclusion is predominantly start early, try to get these patients in as quickly as possible. We are certainly messaging our physicians that we are receptive and open to receiving these patients because of their need for early intervention, certainly working with posture, mobility, endurance, really work their lungs, start them with endurance-based activities, get that lung expansion going, diaphragmatic breathing, get the intercostal muscles working as well as the accessory muscles. Those would be very important aspects of care. All right, and there are my references. I apologize for the last slide. Thank you.
And just a friendly reminder, please make sure that you either click on the link on your PDF or put your smartphone up for the QR code to complete your survey for our wonderful speakers.
First of all, thank you, Sarah, Julia, and Gumti for those insights. Certainly very, very challenging times, but I'm so encouraged and proud of our profession for the way that we have responded, and certainly the three of you are leaders in each of your separate domains, so representing our profession very, very well. So thank you all for your time. We do want to provide some of our general SIG updates that we like to provide at each of our membership meetings. We are going to have to do this at a little bit of an expressed pace, but I think it's well worth it based on what we've heard this morning. So again, many thanks to you three for participating this morning. So just a little reminder about who we are and our leadership team. Myself, Holly, Mary Alice, April, Deb, Courtney, and Emily, working tirelessly. I can't say enough at how inspired I am by these individuals every day, working so hard to really live out our mission and values, and that includes elevating clinical practice so that we can meet the needs of this population and continue to advocate for their needs. So I do want to give April Gamble a chance to give us some very expressed updates. April has a session she's going to be leading this morning at 8 a.m. So April, without ado, I'm going to allow you to pop on and tell us a little bit about what's going on with our newest committee, led by
Great.
you.
Thank you, Lori. Can you guys all hear me okay? That's good. All right, so I have the honor of introducing our Global Outreach Committee very quickly. You can go to the next slide there. So this committee was developed kind of organically through a collaboration between myself and the SIG to support the development of oncology rehab services in Kurdistan, Iraq, which is where I live. And so because that was a successful collaboration, the SIG saw an opportunity and the potential to focus our efforts in working towards a world where all persons can get equal benefits from cancer rehab services. So that's really the aim of the Global Outreach Committee. And as I said, it's new as of this year. And so we're hoping that we can bring together professionals to address systemic barriers to cancer rehab for different populations that are historically marginalized. And we specifically chose the term global in the title because it does refer to global health and the principles of global health, which include principles of health justice. And global health is working both locally within our communities, within our state, within the nation, as well as internationally. And really our platform kind of works on the code of ethics there of the APTA that you see, where we're hoping to reduce healthcare disparities by addressing systemic barriers specifically to cancer rehab. And Emily's going to share briefly one of the projects we've been doing. And you can see some of our members here. And if anyone's interested in learning more, if you have an idea for a project, you would like to be a member of our committee or just even join a specific project, please reach out to me and you can see my email there. And the main thing we would love for you to do is if we really want to to understand what our committee can do to work alongside you and your committees and your communities, sorry. So we ask that you fill out this survey, and I'll ask Emily to put the survey into the chat so you guys can easily access it, and we'll also email it out and put it on our Facebook. It's just a 3-minute survey just so you can share with us what are some ways we could work towards addressing the root causes of inequities that you see in your communities related to oncology rehab. And I am now going to hop off because I have the next session at 8. I hope you're all joining us for the educational session. And I'm going to pass it on to Emily to share a little bit about one of the projects we're doing. So, and thank you everybody else for all your presentations today.
Thank you, April, and good luck. We are excited for your presentation.
We'll see you on the other side.
Yeah, indeed.
So the next slide is, my name is Emily Compagner, and I've been working with April Gamble on a project for the LGBTQIA+ community awareness. This includes the list as follows in the second bullet. And we've been collecting surveys, doing personal interviews with those who identify as part of the LGBTQIA+ community, as well as reviewing research articles with the communications committee, as well as some professionals who are on this call today. And I thank all of you who have helped and assisted us in this process. And with this, we're hoping to create, we've created a handout, and we're hoping to create some more information that helps advocate for this group of individuals, especially relating to cancer care. So if you go to the next slide, there's a picture of the handout that we've created regarding different areas of this type of care, including inclusivity for the community, specifically use of affirmed pronouns and inclusive intake forms, which is really important to connect with this population in particular. And it also reviews different things that are different types of cancer that are prevalent in this population. And the link to that information is the Google Drive link sent to everyone. Go ahead, next slide.
And if you could, next slide, please, Holly. Thank you. There is, and for time purposes, with Emily's leadership and partnership with the students, we have developed educational worksheets from the SIG, which can be shared with oncology, rehab practitioners, or new grads, or those who are just coming into oncology rehab, especially with some of the partnerships of the clinicians on the call, ACSM exercise guidelines for cancer patients, lab values for oncology, symptoms of cancer, cancer treatment, and cancer fatigue and depression. Our SIG is planning on a call or conference in the genitourinary cancer patient with Holly's excellent leadership coming early 2021. So please check out those for upcoming educational sessions. And if anyone has any options or wishes for other sessions, please put those in the chat box.
And for the research committee, can you go to the next slide? So I just want to thank our research committee. This is just a wonderful group of professionals that are working very hard to bring 2 different article reviews per month, and we're utilizing the cancer awareness of the month as kind of our way to decide what we're going to talk about. We also have some additional reviewers that have stepped up and are helping us review. And this is so wonderful. We've gotten a lot of good feedback from everyone about the reviews so that we get some conversation going on the listserv. Of course, we always post everything on the listserv, but that it is also being transferred over to the website, so you can look at those later, and they can also be used to write up some of your documents to use for PDRs as well. So thank you to everyone who has helped us.
Okay, now we're going to go through the communications committee. The pictures that you see below, as well as Nicole Daly, are part of the communications committee. I'm so thankful for all the work they've put into everything that we've been able to produce from this committee so far, and we have a lot on the horizon. We're looking to do more with telehealth and oncology rehab, and the importance of those things in the future. So look for more things to come from this, as well as the next slides. We'll show you the educational handouts that we've been working on. If you keep going, the students will give a quick, like, one sentence overview of each of their slides. So
this is just an educational handout that was made to compile lab values important in oncology patients, just to help clinicians interpret their meanings and interventions for physical therapy in one document.
So this handout summarizes all the current evidence-based ACSM recommendations for oncology population in regards to intensity for both aerobic and resistance training. We have on the back some quick references in case someone needs a quick calculation for intensity of heart rate or reference to RPE scale, etc.
This handout was just focuses on some cancer-related emotional changes. It's just a brief overview of the emotional changes that people might experience. So we just focused on the suicidal ideation, cancer-related depression, and treatment for the cancer-related depression. And then this one, as you can see, is related to cancer-related fatigue. So we just focused on the definitions of cancer-related fatigue, the presentation and symptoms that we might see as clinicians, the science behind the cancer-related fatigue, and the treatments. And then this last one is cancer-related fatigue, or I'm sorry, cancer-related seizures, vomiting, and nausea. So it just touched on the prevalence of the cancer-related seizures, reducing the onset of seizures, as well as what to do if a patient has a seizure. It also focuses on the timeline for cancer-related nausea and vomiting, and then also risk factors for the nausea and vomiting, as well as treatments.
So these are the oncology rehab SIG endeavors that we've had so far, as well as things that we're looking to do in the future. And so far, I feel like we've gone above and beyond connecting with the entry-level students, and we're continuing to do that and connect them with other providers. So just keep an eye out for more in the future from our group.
Thank you, Emily. Oh, go ahead.
Oh, here's all the things that we can connect with us, the listserv, the webpage, as well as our Facebook page. Please join any of them. We'd love to have you as part of our group. Go ahead, Lori.
I just wanted to extend my sincere thanks for those projects, especially. I know that the students have been working very hard on those, and we are very grateful and so very proud of the final products. Really, really exceptional work that will be used by clinicians as well as students and new graduates. So just exceptional work. So true thanks to you guys for that hard work. Thank you again to our speakers. I am so impressed we were able to cover 67 slides of content in an hour. Impressive work to all. Continued thanks to the leadership team. Again, I am so proud to work among you guys. You inspire and give me motivation every day to continue and to labor for this population. So thank you again to all of our participants this morning. I think this is our most successful in terms of attendance meeting to date. So you guys are doing the hard work too, and we applaud your continued efforts there. If you guys are attending the conference, please enjoy. Again, April's session is unopposed this morning from 8 to 10. So I'm going to be popping off to learn about how I can be a little bit more equitable in my practice. And with that, I will say have a wonderful fall morning. Julia, go back to bed, maybe. And I will bid you all adieu.